This is eRadio.
It is time for the very first edition of Medical Monday on eRadio, and we've been looking forward to it for so long. Dr. Dylan Joseph joins us this afternoon, ophthalmologist and also eye surgeon. Today, he's going to introduce himself, in case you haven't seen our article on him yet, and we'll be talking about where exactly his passion started for it as well, and talk about a few interesting terms and advancements in technology. Dylan, Dr. Dylan, good afternoon to you. How's it going?
Good afternoon, Ian. Thanks very, very much for having me on the show. It's a great privilege, and I think what a fantastic initiative that you've got here going, and flying the Southern Cape flag high. Very proud to be part of the show, and hopefully we can take ophthalmology and understanding refractive surgery and a bit more about the eye to our people of the Southern Cape and beyond.
It's so interesting. We just spoke about it off air, and there's all these terms. And today, I'm learning a lot as well as we go along. But let's go back in time. And I mean, you've got a very impressive CV. Let's talk about your passion first, and what got you interested.
Yeah, so Jan, we go through medicine obviously first, and that's 6 years of studying at varsity. And then in South Africa, we've got compulsory years doing our internship and our community service years. And very often we end up in a peripheral hospital during our com service years. And that gives us exposure to a broad range of disciplines. And I was very lucky enough on the northern coast in KZN there in Mpangeni to do 6 months of ophthalmology in my community service year. And I stayed on as a medical officer for another year there. And it was in that time where I realized, the power of, changing lives through changing vision. We used to see people that were literally brought in with a white cane by their aunts and uncles and children because they couldn't see where they were going.
Wow.
And if you think about cataract surgery as a commonly performed procedure, and cataracts are the most common cause of reversible blindness in the world. And I remember vividly, I used to have a list on a Friday, as a junior does, of course. And that means the ward rounds are on Saturday mornings. And it just still gives me goosebumps to this day, taking those patches off the eyes. Oh. And in unison, we had 5 or 10 people just singing in Zulu songs. Wow. And it was a life-changing moment for me. And from that day, I decided this is what I want to do. I want to be in the line of changing lives and empowering people to see again. And for me, there's no greater gift than to bestow that upon someone. And from there, I worked in another peripheral hospital in Kroonstad for a year, looked after that eye department before specializing for another 4 years in Bloemfontein. Now, Bloemfontein was a wonderful varsity, had fantastic education, and then went straight into private practice. And moved to the garden route from 2012 to 2015. Moved down here and practiced general ophthalmology and really enjoyed that. And then during that time, had the interest, or developed the interest for refractive surgery. Basically, in 2013, 2014, I got a call from a colleague who trained me in Bloemfontein. And he said, would you like to consider doing laser vision correction in knysna? And laser vision correction is not something that as a postgraduate, meaning while specializing, you get a lot of time in. And so he was my mentor basically in laser, and he brought down a laser vision correction unit, installed it. He helped me with my first few lists and got me going. And that's really what ignited the passion. And from there, I got the opportunities to go and do a few courses overseas. And then a game changer was following this passion to a world leader and pioneer in laser vision correction surgery in Dublin, Mr. Arthur Cummings. And I was fortunate enough to spend 2 years with him and immerse myself just in vision correction technology. So basically anything to help you reduce your dependence on a contact lens, a spectacle, a pair of reading glasses, and if you've got cataracts, to look at the technologies to help you, improve your vision with cataracts. And a lot of those technologies can now help us be spectacle or contact lens independent from there as well.
Dr. Joseph, you're also a pioneer in the garden route in terms of getting a new technology here first, I believe.
There are a number of really good units in the country that have a laser vision correction technology. In the specific laser that I use, though, is the same one that I brought back from Ireland, the same technology. And with regards that one, yes, that's called a suite, a refractive suite. So it's got 2 laser systems. So there's no blades to create our flaps when we're doing what's called Lasik nowadays. It's gas, it's plasma, it's bladeless, it's painless. There's no knives, there's no needles. And yes, there are 2 of those specific suites in South Africa used to do the Lasik with the flap, and then to do the laser excimer ablation. But there are other suites in the country that still use that same laser technology, but just different companies that supply it. So from that perspective, I was used to the technology I was using in Europe. Our nomograms were refined. I was getting the same outcomes as as Arthur Cummings, who was teaching me. And so I decided, well, if I want to come back to South Africa, I wanted to be able to provide the same platform with the same results. And that was my motivation for bringing back that same technology here.
Wow, very, very interesting. Just, Dr. Joseph, tell us, what exactly is refractive surgery? What does that mean exactly?
So refractive surgery is changing a person's eye to see the way a spectacle or a contact lens or a pair of reading glasses would have done. We're changing the way the light rays bend through the eye.
Wow.
To make those light rays fall at the perfect spot at the back of the eye for clear vision. So refractive surgery encompasses a number of different procedures. So the first procedure that we can chat about is something called laser vision correction, and there it's subdivided into Lasik. Lasik is where the one laser I told you about now creates an ultra-thin flap on the top of the cornea, and we can program these lasers now to create 100-micron flap. That's 0.1 millimeters in thickness.
Wow. With
a perfect edge on a 5-millimeter hinge. So the architecture is really better than anything else can do in current day technology. So the recovery of LASIK is super fast, and people are generally seeing within 4 to 6 days what their contact lenses and their spectacles gave them.
Wow.
The alternative to LASIK is to do what's called a surface treatment, and on our platform that's called Streamlight, which is a one-step no-touch technique, which is really elegant. It just takes a bit longer to recover visually, and the 3 and 6 month data show that the visual results are identical to LASIK. We make that decision based on the patient's anatomy, based on their scans, and what's going to be the best procedure suited for their eyes. If they're not a good candidate for laser vision correction, we can consider something called an implantable contact lens. Now, sometimes we see patients that are minus 15 or plus 10 or plus 7. They're outside what we call the FDA guidelines, the Food and Drug Administration guidelines of laser vision correction. And if they've got enough space in their eye, we don't fiddle with their natural human lens. What we do is we plant a very special contact lens over their existing lens. It's impossible to see it to the naked eye. It's as quick a visual recovery as laser vision correction, and it can correct a broader amount of refractive errors than what laser vision correction can do. So these are generally people from 18 years. So anyone from 18 years upwards, can consider a form of vision correction in terms of reducing dependence on contact lenses and spectacles. And then generally our second category is for the people at 45, 50 and above, where we start getting what's called the short arm syndrome. So I'm sure you've heard of, there's a term called presbyopia, and we're all going to go through it when we hit our 40s, and that's loss of our near vision, essentially. And it's something we mourn, because it's something that we've always had for 40 years, and suddenly now it's gone, and it was a crutch that we relied on, and we're not able to see our cell phones, we're not able to read anymore. And now suddenly that's gone. And we can still do laser vision correction in this age group, but if you're not a good candidate for laser vision correction, we can consider then removing the human lens in something called a customized lens exchange. The old thought that a cataract needed to ripen and be present there before removing the human lens is basically a redundant way of thinking. If you're looking at a visual Solution, 96% chance we're able to get you something. And we can apply the same with cataract surgery. When we remove that human lens or the clouded lens, we're implanting a lens with a technology that can give you a certain range of vision depending on your visual lifestyle. So you may do 40% of your day reading at a Mac desktop distance or on a Kindle, or you may spend 40% of your day at a desktop, or you may do 90% of your activities outside. So we have special monitors that can actually pick up and show us with artificial intelligence how much time you're spending during the day with those activities.
Wow.
And we can then develop what's called a lifestyle match index for you based on this artificial intelligence to choose a lens that is going to suit your lifestyle. So it's going to give you the broadest range of spectacle-free or contact lens-free vision if that's what you are desiring. And that's what we've got available. That's what refractive surgery is. Refractive surgery is essentially changing the way light falls through the eye to make it fall on a point that gives you good, clear vision.
Wow, what an explanation. Thank you so much. Listen, it actually sounds like you're from the future. I can't believe all this is actually happening in 2021. Yeah. But I mean, it's incredible the technology you're working with.
It is, Jan. I think laser vision correction or refractive surgery is one of the subdisciplines of ophthalmology or of medicine that is evolving the most rapidly. It's at an incredible pace. And refractive surgery itself is such a subdiscipline that I belong to a college of surgeons called the Refractive Surgery Alliance. It's an international body of surgeons who are refractive surgeons specifically. And it's actually so detailed and so involved that they are looking at creating refractive surgery as a complete subspecialty away from ophthalmology, from general ophthalmology. And I think that's the way general medicine is moving anyway. If you are looking for a retinal surgeon, you've got a retinal problem, you go to a retinal surgeon nowadays. If you're looking for blepharoplasties or eyelid lifts, you're going to see someone that only does cosmetic or functional plastic surgery. It's the same with knees, same with hips, same with hearts. Everyone is sort of developing a niche market and getting really, really good at a smaller amount of components, essentially.
I'm looking forward to a more in-depth discussion in the weeks to come where we'll talk about laser and especially the myths, because there's a lot of myths going around, and it's always nice to have a bit of a myth-busting session. But I just want to ask you, you mentioned that somebody could be or could not be a good candidate for laser. Just want to ask you quickly, what would that mean? How would you know that somebody's not a good candidate for laser?
Yeah, that's a great question, and it's a question that we often debate at our meetings as well. So, even amongst refractive surgeons, we will look at a number of patients and a number of scans and say, is this a good patient for either a laser or a lens-based procedure? Now, in general, 96% of people who would like a refractive procedure would qualify. And then that's where our job becomes important to say, well, what procedure is going to be the best for you? So we take a very detailed history from the patient. So family history is really important. So if a patient has a disorder of the cornea called keratoconus, which, if you can imagine a rugby ball that Mornay Steyn got hold of 12 years ago, and more recently in the British and Irish Lions tour, and zapped it through the poles and distorted it really badly. That's what a cornea looks like. It's a distorted rugby ball shape. That's called keratoconus. It's a genetic entity, and these patients are contraindications for Lasik. They are not necessarily contraindications for reshaping the surface of the eye to better fit a contact lens or a pair of spectacles, and that's a totally different talk. We've got technologies available now called topography guided lasers, where we can map the shape of your cornea, its lumps and bumps, put it into the software, and the software says to smooth this out. To give it the most optically smooth surface, this is the laser profile we need to do. In these cases, it's not to get people out of spectacles and contact lenses. It's important to remember that for keratoconus. But it does often help if their corneas are thick enough to help improve their quality of vision with a spectacle or contact lens. So those patients would be a contraindication. People that are perhaps ladies that are breastfeeding and are pregnant now are an immediate contraindication, but 3 months after cessation of breastfeeding or pregnancy, then we can certainly consider their laser vision correction options. Some certain autoimmune conditions are important to watch out for, and that's why history taking is so vital, because certain conditions may have a predisposition for scarring, and if your conditions are uncontrolled, then we may consider postponing laser vision correction. So, and if the patient's corneas are just too thin, and they've got a lot of warning signs on them that they're not stable, then we would rather look to something like an implantable contact lens procedure. So at the end of the day, as I've said, you may be not be a great candidate for one procedure, but as a refractive surgeon, it's our drive, it's our passion to try and find you a procedure that may suit you and is going to, at the end of the day, give you the same visual outcome.
Wow, that's so fascinating. I also want to ask you, Dr. Joseph, cataract surgery. Is it true that cataracts only come and appear on the eyes of older people?
So by and large, a cataract is something that we're going to develop as we expose ourselves firstly to more ultraviolet, because ultraviolet changes the lens structure and makes it more brown, so to speak. So when it goes brown, it can't filter the light rays through. So the cataract symptoms are classically, people are cleaning their glasses more often, they're turning up the bedside light to see better, and their spectacles are getting renewed or updated every 3 months because those cataracts are getting harder and harder inside the eye. Yeah. And very often people's nighttime vision starts to go for a loop as well. So they complain of glare and things aren't as clear. So, and as we get older, generally from 55, 60, 65, yes, cataracts are an aging phenomenon, an ultraviolet phenomenon. It's going to happen with all of us. But there is a subset of people who perhaps have other metabolic disorders like diabetes, and they can develop cataracts at a very early age, in their 20s, in their 30s. Wow. And they would need surgery to have those cataracts removed. And once again, you can still consider, premium lens implants to try and reduce their dependence on spectacles. And some are congenital, meaning some people are born with cataracts, and it's a hereditary problem. And those need to be picked up very early and sorted out very early, because if a cataract is left in a child and it's big enough, a child's first formative years are in those first 7 years of their life. And if there is an impediment in their visual system, then the brain actually switches off the development of the nerves to that eye. Wow. So it suppresses it, and beyond 7 that can be potentially irreversible. So there's a number. It's not just confined to older people, but by and large, yes, cataracts are something that we're going to develop beyond 55, and we find it more commonly in our southern hemisphere climates, and the reason for that is ultraviolet. Our UV index in southern hemisphere countries is much higher than in the northern hemisphere. So where I worked in Ireland, the presentation of cataract development tended to be a lot later. So in your 70s, 80s, and 90s, as opposed to your 50s and 60s here in South Africa.
Now, cataracts, what exactly is happening in the body that's causing cataracts? Is it just the growth on your eye, or like a little lens that,
Yeah, so that's a great question, and I wish I had a video to show you. And we've got some great 3-dimensional video software that I show my patients at the practice. It's a common misconception that a cataract is a membrane that grows on the outside of your eye. It's not that at all. So inside your eye, behind your pupil, so the pupil is that little black hole you see in the middle, right? Yeah. The iris is the colored part around the pupil, and behind that structure you've got the human lens. Now the human lens is attached to tiny little ligaments, which are in turn attached to muscles, and those muscles control the ligaments and then in turn control the shape of the lens. So depending on whether we are focusing on an object for near or focusing on an object for distance, these muscles either contract or relax to allow the lens to become more globular or to become flatter. So the light rays then change their effective position where they're falling at the back of the eye. Now, cataract development, it starts with actually a process that we undergo called dysfunctional lens syndrome. And that typically starts happening in our 40s. It doesn't mean we've got a cataract. It means the lens inside the eye is starting to dysfunction. Why? Because it starts to develop or undergo a process called sclerosis. And sclerosis is hardening. All right? Apart from the hardening, due to a number of metabolic processes that happen in the lens, it starts changing color as well. Not only that, but the muscles and the ligaments around that lens start slowing down. So it's like gymming. You know, you go and do a repetition of a bicep curl, and you can only do so many before that bicep starts taking strain. In our eyes, we can do millions of bicep curls until we get to our 40s, and those muscles then start slowing down. And when they start slowing down, that's when you lose your near vision. This is when we start referring to what's called the dysfunctional lens syndrome. So getting back to the talk about, you know, removing the human lens, we can remove a human lens if it's dysfunctional, not necessarily only if it has a cataract. It just depends on what's going to best suit you. But the cataract is a clouding of the human lens. It comes from the Greek word, and basically that clouding happens in the meat, in the substance of the lens. And as it starts clouding over, becoming brown yellow, imagine trying to shine a light ray through a frosted pane of window. What's going to happen to the light on the other side? It's going to scatter, isn't it? Yeah. So your image quality on the other side is going to degrade. But the same thing happens when the human lens is cloudy. As the light rays travel through it, they're going to scatter. So people's image quality starts degrading. So it's a common misperception that a cataract is on the outside of the eye, and it's not something we scrape off. But we do need to take you to theater. And I mean, with today's modern ways of anesthesia and technology, it's so minimally invasive that we do our surgery under topical anesthesia, which means drop form. So all we put is numbing drops onto the surface of your eye, and our anesthetist puts up a drip for you that it makes you very drowsy. So you're not asleep, and you literally, you're in theater 20 minutes, half an hour. You go home with a clear eye shield. So not in the old days where you had to actually sit in a dark room for 3 days with a patch on the eye. Oh my. I mean, all our wounds that we make are self-sealing. It's 2.5 millimeter wounds. There's no stitches involved. And you basically are, in 98% of cases, up and running and functional the next day. So it's certainly a procedure that a lot of people have fear, because I agree, it's your in my opinion, it's your most precious sense. There's a big debate as to whether hearing or sight is the most precious of the senses. But you know, so people's concerns and questions are very valid, but that's what ophthalmologists are there to answer. They, you know, to put their minds at ease, and very often after a person's had their first eye done, they say with a smile on their face the next day they're looking forward to the next one.
Wow, that's so cool. Can you see when somebody's got a cataract? Can you actually see it on the person's eye?
So unless it's a very dense white cataract, basically stage 4 lens changes, what we call stage 4, are the most advanced cataract changes where they become white or brunescent. So yes, those you can see, and those are the type of cataracts I was referring to in my Nguelazan days up on the north coast, where no light gets through, or very little light. What the patient can then perceive is literally shining a light. They can't see your hand, they can't count your fingers. That's a really dense, hard cataract, and you're not going to miss that with the naked eye, basically. But when you're examining patients, we've got new diagnostic tools now, especially for the younger patients, where we are considering, do we do laser vision correction, or are we going to do a lens-based procedure? We've got a machine called the HD analyzer, which measures scatter off the eye. So it actually sends rays through the eye, which can determine if there is significant scatter coming off the lens. And remember, I told you, earlier, one of the symptoms or one of the problems with the cataract is it causes light scatter. We can't see light scatter clinically, and we may see very, very early subtle changes in the lens. But these machines quantify the change for us to say definitively, yes, we should be looking at removing this lens because there are early signs of cataract. But most of the time, we're looking at an eye or looking at the lens under 16, 25, 40 times magnification. And when we put drops into the eyes to make the pupils nice and big, we can really examine the lens under high magnification and get a really good idea as to the discoloration of it. Remember, cataract changes are often picked up with yellow, brown hue or tinge to the lens, and then obviously a reduction in their vision quality. So people may come to you and say, well, look, I'm not seeing as well through my specs or my contact lenses as I used to, and I'm cleaning my spectacles more, and I just, I can't see. I have to turn the bedside light up brighter to read at night, and just my quality of vision just doesn't seem what it used to be. And you can test their vision, and sometimes the only way we pick up cataracts is because there's a slight loss of color. So we can measure that as well. They may still be seeing pretty well with their specs or contact lenses, but if there's a slight loss of color and it's affecting your quality of vision, it's affecting your quality of life, then we must do something about that.
Yeah, exactly. Dr. Joseph, just in closing, am I correct in saying that your main goal is to get people to be less dependent also on glasses and on contact lenses?
Well, I think it's become a passion of mine because I see the difference that it makes to a person's life. I think, any form of eye surgery, being more specifically cataract surgery or laser surgery, changes quality of life. And that is my passion. And not necessarily, we're not going to get everyone out of spectacles. And there's 4%, 5% that we perhaps can't get completely spectacle independent. And there's a counseling process because most of the options that we have or that we show you do involve some form of compromise. And it's important that the patient sits down with the surgeon and discusses that journey and sees which form of compromise is going to be best for them. But at the end of the day, my patients that come to me say, well, I'd like to be out of glasses for my reading and for my distance. And being able to empower them with that gift or give that gift to them is what drives me. So in summary, I love what I do. I love the surgery, but mostly I really enjoy the difference that it makes to people's quality of lives. And some patients with cataracts come to me and they say, listen, they want to be back in their spectacles because they feel naked without their spectacles. And there's definitely a number of people that do. And that is absolutely 100% perfect. And it's important then afterwards that we say to these patients, right, at the 6-week mark, once they're settled, here's a referral letter back to your optometrist, and they can have their varifocal spectacles made up, or their readers made up again afterwards, or their photochromics. A photochromic is something that tints as you go from inside to outside, so it goes dark. There's fantastic technology in that realm as well, and it's entirely dependent on the patient and their lifestyle. What is their choice? And I try my utmost best to cater for their visual demands and their choices made.
Well, this is so interesting. And that's it for our first edition of Medical Monday with Dr. Dylan Joseph. Dr. Joseph, how do we get in touch with you?
Yeah, so we're based in knysna. Our offices are here. Our landline is 044 150 0085. Alternatively, we've got our website, and all the contact details are on the website as well, and that's www.dr for Dr. Dylan Joseph, DYLANJOSEPH.com. And the email address is on the website as well, and Mariska or myself are happy to take questions, and we often do. We something that evolved through the lockdown as well, Ian, was online consultations and virtual consultations. Wow. And we've opened up an app through a link called Calendly. And, if people are wanting to explore their options of spectacle and contact lens independence, then they can go straight through to that app. and book a 15 to 20 minute chat with me, I can actually share the screen and I can show them 3D animations of what laser vision correction is like, what cataract surgery is involved in, and what technologies are available to them. So, yeah, although I suppose COVID's had its run with the world, but it's actually opened a few different avenues and that we've been able to explore, and hopefully empowers people to make better decisions on their vision.
Absolutely, and our listeners, of course, can also click on the banner on the eRadio website, which will take you right to Dr. Joseph's website. What an interesting and insightful conversation today. I'm already looking forward to next week.
Absolutely, on me too. And once again, thanks so much for the opportunity. And I hope we've given a few nuggets to our listeners out there.
Absolutely. Looking forward to next week. Thank you so much, Dr. Joseph.
Thanks, Ian. All the best. Have a great evening.